Good afternoon, this is Goeran, Fiedler speaking. As you can see, you cannot see me because I'm out of town today. I'm sorry about that, but I'm gonna speak with an accent again, so perhaps you can recognize me by that. My topic today is the objective evaluation of socket fit in artificial limbs. To start with a few words about prosthetics in general, the background of this kind of studies. A prosthesis in general consists of various prefabricated modules. Well, most of them are prefabricated, such as, for instance, the knee joint, or the foot part, several of the adapters. Pretty much all of the mechanical parts come off the shelf, are sold by the orthopedic industry. The individual part is essentially just the socket. The socket has to be fitted to the patient, and then of course there are some factors like the alignment of the prosthetics, the statics, the adjustment of the standardized parts, for instance of the knee joint, that also contribute to the overall performance of the prosthesis. And other factors that must be mentioned, of course, are the factors that the patient himself or herself brings to the table, so like the general physical ability, health status, also perhaps the motivation to work with the prosthesis, and generally the perception of the prosthesis as something good or something bad. So if you look into the field of research and development in prosthetics, most of the work is actually done in this field of standardized parts. So you can see here, for instance, a couple of prototypes of electric hand, I guess, some of the foot prototypes that are in development or already in the market nowadays. Those parts are kind of interesting for the orthopedic industry to develop and improve because they can be sold in high numbers. Like so many things, if they are standardized, to come up with one good idea, you can build a few thousand copies of, for instance, this foot here, sell that with a profit, and of course that makes sense. So there's quite some incentive to bring this part of the field forward, and accordingly we are at pretty high level nowadays. This is pretty much the high-tech aspect of prosthetics. However, there are, as I mentioned, other factors that go into the performance of a prosthesis, and such are the alignment and the adjustment of the parts. And of course there are also studies done in this field. However, most of them are more non-profit oriented institutions like universities and so on, who do, like we see here on the right hand side, gait analysis with amputees. If you look closely, you see that this participant there has two below knee prostheses bearing the usual reflective markers that we all know so well from the gait analysis. And on the left side there's a small adapter that goes into a prosthesis if there's space for it. That is pretty much a mobile gait lab. Picks up, has a couple of strain gauges in it, and picks up all kinds of forces, moments, torques. Delivers quite interesting data obtained during walking in the field, not in the gait lab. And finally we have the question about the socket. And the socket, as I said before, is the most individual part. There's almost no way of generalizing any concept or finding that sure there are different concepts, but since every socket has to be fitted to an individual patient, there's mostly no way of making this a standardized business. So there are of course improvements in this field as well, but they usually result in some solitary prosthetist who's been working in the field for many years and decades, and finally, after this long years of experience, comes up with an interesting new concept that he tries out successively with a couple of different patients, and after many years that might become the new socket concept. And one of the questions or the difficulties that comes with assessing the socket and determining if the socket is good or not lay in the fact that there are just very few subjective or objective means. Sorry, subjective. There are some. Can start here with questionnaires. On the right upper side you see this visual analog pain scale that is used in many fields, and one of the fields is of course prosthetics. Other measurements would be pressure contact pressure measurements that are done with thin sensors that are applied or placed in the socket between the skin and the socket wall. And then a little depiction of the outcome is in the lower left corner. And then eventually we have imaging techniques like X-rays that help see the internal conditions between or inside the prosthetic sockets, which are obviously elsewhere hidden from the eye. So for the remainder of this presentation, I'm going to focus on the skin socket displacement, which by many people is considered the most objective measure of socket fit. I already mentioned that questionnaires are a little bit hampered by the fact that the answers are not really comparable with each other. So some people perceive pain than other people. The pressure sensors themselves have some technical issues like pretty high drift and hysteresis in most cases, and also they are not really unobtrusive. They influence the conditions inside the socket. If you put the sensor in there, there's less space for the stump, and also the surface changes, this gets more slippery or things like that. X-rays, of course, also come with certain downsides, so they bear some risks for the subjects, being ionizing radiation. However, they allow finally the visualization of the stump-socket interface that we are so interested in. This is the protocol for DRSA. That stands for Dynamic Röntgen Stereochromatic Analysis, and in order to do that, the patient has to be prepared with some markers that are taped here on the skin. Those are just athletic tape equipped with some metal filings, and those filings and this metal leaves a signature when it is the patient walks through the image space, so that the X-ray intensifier picks up the signature of those filings, and this helps later on in the tracking process. Our markers are placed, of course, on the socket, and then the trials are pretty much the same that are used in gait analysis, simple walking, or you can have running if the patient is fit enough, things like that. In the result, we get information on the stump socket displacement. If you look closely here at the left-hand side, we have two pictures of the same stump. This is a transtibial stump below the knee amputation inside the socket, once before the step down trial and once shortly after in the lower picture. Perhaps you can see that there is a certain displacement happening in this case, vertical displacement, also called pistoning. The stump just sinks in quite a bit during this impact, and this can be used as a viable criterion to tell if the socket fits well or not. Well, we would assume if the socket fits well, there should be a very low amount of pistoning. If it's too loose, obviously with every step there's going to be some displacement between the stump and the socket. On the right hand side is just a little more elaborate depiction of what those single markers or marker pairs are doing and what directions they move during this trial. This is kind of difficult to translate or to present those findings. What we did here was compare a trial with I think 10 different patients and try to correlate the findings, the displacement that I was just talking about, with some anthropometric factors such as the body weight, or BMI in this case, or the stump length, stump volume. And although these correlations are not really strong, you can see a little bit of tendency that, for instance, longer stumps or more voluminous stump lead to higher displacement. And thinking about that, this is kind of surprising. We would assume if the stump is long enough, has more surface, there would be lesser displacement, because there's just more contact area to provide the suspension between the stump and the socket. But this seems not to be the case, and of course this is a finding, one of the findings that make it interesting to look at this data that have so far been not available. I just want to mention a couple more studies that have come out of the UWM lab here in the past. Pretty much all looking at this kind of questions. And as I said, it's contributing to the body of knowledge in the field of prosthetics, as it provides information on this data that have not been available before. Well, my 10 minutes are up. Thank you for your attention, and I hope to see you sometime soon again.